Welcome to our sonography lecture on renal pathology, part 13 of 14, bladder pathology for the sonographer. This lecture will cover bladder diverticulum, cystitis, and bladder tumors. So when we're looking at the bladder, the best way to look at the bladder is with cystoscopy. And what that basically is taking a camera, inserting it through the urethra and into the bladder. So they can visually see with a camera and a little light, a little bit of fluid in there, they can see the walls of the bladder fairly well. This is one of the better ways to diagnose neoplasms because transabdominal ultrasound can't see a tumor until it's about 5 millimeters or larger. The cystoscopy can zoom in on things, uses the physician's eyes to look around, and as long as they visualize all of the bladder wall, they could see much smaller structures. Now, ultrasound is becoming a little bit more diverse in the way that we use ultrasound, and there is a newer method called Transurethral Intravesicular ultrasound, and so that's basically the same idea as a cystoscope, but this time it's inserting a very tiny little catheter that has an ultrasound or piezoelectric material on the end, so they can ultrasound the bladder from the inside. But as of right now, cystoscopy is still the preferred method. Ultrasound can be useful for detecting large stones, for evaluating the walls, for looking for debris or other abnormalities of the bladder. Now, there are tons of reasons why somebody's bladder might not empty. And urinary retention is one of the bigger reasons why we get ultrasound orders. People feel like they can't get it all out, or they feel like they're going way more often than they should. And so some of those things that cause incomplete emptying of the bladder include bladder calculi. So those are stones that are stuck in the bladder. Diabetes can cause it. Foley catheter. Foley catheters are a type of catheter that are typically inserted into patients that are in the hospital that either cannot or should not be getting up to go to the bathroom. And so this Foley catheter is inserted into the urethra. There's another little tube that is injected with saline and that inflates this little balloon inside the bladder so it stays in place. And then that allows the urine to empty out of the bladder through the catheter into a bag that goes with the patient wherever they may go. So it's very common that we can see Foley catheters in the bladder for our inpatient studies. Inflammation of the bladder wall can cause the bladder not to empty completely. Neurogenic bladders, that basically means that the bladder does not respond to the nerves or tell the nerves that it's full. So the patient doesn't recognize that they have a full bladder or that it's completely empty or that they still have a little bit in there. And so it just doesn't respond the same way that a non-neurogenic bladder does, and therefore can retain some urine. Neoplasms, both benign or malignant in the bladder, can cause incomplete emptying of the bladder. Post-surgical intervention, so sometimes women after hysterectomies have a hard time with it. Colon surgeries, rectum surgeries, it's all kind of in that same area. They can cause some issues with that. Pregnancy can make it difficult to evacuate completely. Radiation therapy, rectal or vaginal fistulas, renal disease, sexual intercourse, trauma, blood clots that are stuck in the bladder can cause incomplete emptying, tuberculosis, and finally urethral stricture. So the actual urethra coming out is narrowed, therefore making it difficult to empty completely. So tons of reasons why a patient may not be able to empty. And our job is to see if we can find any of these. Most of these we can have some role with in helping to find, especially looking for blood clots, supplementing with pictures of the kidneys to figure out renal disease, pregnancy, neoplasms, inflammation, Foley catheter. All of those are things that we can kind of look for with ultrasound. So just speaking of some of those things that kind of causes issues, we talked about the urethral stricture, and one of the ways that the urethra gets commonly kind of shut down is because of an enlarged prostate. So here is the bladder in transverse, and we have this large prostate underneath it. This is the bladder and long, again with a large prostate inferior to it. Now, the urethra is actually coming out right here, and the urethra travels through the prostate. So as the prostate enlarges, it's going to put more pressure and squeeze down on the urethra, which makes it very difficult for the patient to create enough oomph, basically, to get all of the urine out. So men with enlarged prostates tend to need to use the bathroom more often. They feel some urgency with that, or they don't empty completely, as we can see in the picture here. I had mentioned Foley catheters earlier that these are a very common finding in our inpatient renal studies. When you're scanning through the bladder, you will see this little bubble down here, and you should know if they have a Foley catheter in. They come along with a urine bag to hold the urine as it empties out through the catheter. As I had mentioned, a tube is inserted in through the urethra. This bubble is deflated at that time. There's a second tube that they can inject saline into to inflate this bubble. So this is a little plastic bubble filled with saline, and then that's going to help keep the bubble in place, holding the catheter in place. There's actually kind of a channel within the bubble that connects with the catheter tubing that allows the urine to exit the bladder. So our first pathology that we're going to discuss is bladder diverticulum. Now, bladder diverticulum is defined as herniation of the bladder wall causing outpouchings. And these can be a single outpouching, or you can have multiple outpouchings on various surfaces of the bladder. On ultrasound, we are able to detect these fairly well. If the bladder is relatively full, what we'll see is kind of an irregular wall on the urinary bladder, and then it's going to be these little pouches that come off of the side of it. So here's an example of a couple bladder diverticuli. We have the main part of the bladder, and then there are these little herniations of bladder wall. So the bladder wall comes down here, pouches out, and then continues back around. So you can see these little channels. Urine comes through here, in through that little channel, and fills up the diverticuli. Now, these are not as apparent when the bladder is empty because all of the urine does come out. Sometimes as the bladder starts to deflate, these little channels kind of get blocked off, so we can catch some urine within the diverticuli, even though the main part of the bladder is empty. That urine, if it gets stuck in there, that urine stasis can cause problems. It can cause inflammation. Particulate can start to form, so we might start to see some debris within the bladder if the bladder does not empty completely. Cystitis then is another pathology that we are able to see by ultrasound. Cystitis, if we break their word down, cys refers to the urinary bladder, itis refers to inflammation, so this is inflammation of the bladder. And again, this is usually brought on by urine stasis. So if a patient is unable to empty their bladder due to those multiple reasons that we just saw, then that urine sits in there. And as the urine sits in there, it starts to concentrate, it starts to get kind of irritating to the bladder wall, and then we start to have an infection. And so that cystitis, that urinary tract infection, can travel up to the kidneys. Sometimes it's brought on by outside sources like E. coli through the urethra and into the bladder. Sometimes it's brought on by sexually transmitted diseases, can cause cystitis. So multiple infectious and non-infectious causes can result in cystitis in the end. Now, on ultrasound, we expect to see a thick bladder wall. Despite the bladder actually being relatively full, it's still going to have a pretty thick wall. Anything over 6 millimeters, deflated or completely full, is considered thick for the bladder. And then oftentimes we will also see mobile debris. Now, if you think a patient has cystitis, it's important that you roll them around. Oftentimes that bladder kind of settles down, or that debris in the bladder kind of settles down to the posterior side of the bladder wall. And you won't see it unless you roll your patient to maybe look for the kidneys and then happen to go back to the bladder just in time to see that debris move around. The other way that I tend to see debris quite often when I'm scanning is when the urinary jets come in, they kick up that debris, and you'll see some debris kind of float off into the main part of the bladder, and then you'll see it kind of sprinkle down. So here is an example of cystitis. We have a very thick wall measuring 7 millimeters. This is very thick. This is positive for cystitis. Lastly, then we're just going to talk a little bit about bladder tumors. We had mentioned earlier that transitional cell carcinoma is the most common carcinoma of the collecting system. We do consider the bladder part of the collecting system. So 95% of the tumors found in the bladder are transitional carcinoma. Unfortunately, most of these cancers are not found until very late stages, so it is not always going to have the best outcomes, but sometimes we do see them incidentally. When I have been scanning aortas, I've been coming down to the iliacs, going past the bladder, I have seen cancer a couple times that way. I've had colleagues that have found cancer doing pelvics on women. They came in for some sort of GYN exam, and then because their bladder is full and it's in the pictures, we incidentally had found cancer that way. So always take a look through the bladder if you're down there. It doesn't hurt just to take a quick look through. You might actually save somebody's life or get them treatment a little bit sooner. Now, when a patient has kind of later stage transitional cell carcinoma, one of the first things that they're going to notice is that they have blood clots in their urine. So we call that gross hematuria, when they have chunks of blood that they can see in their urine. It's also painful to urinate, and they feel like they have to urinate a lot. And when they have to go, they have to go. There's urgency to the feeling of urination. Typically on ultrasound then, what we will see is an irregular wall thickening that is kind of focal to one area. So here's an example of a bladder tumor. We have the urine in the bladder here, the bladder wall, and off to the side here we're seeing this focal thickening of the bladder wall. This one happens to have some color flow within it. Here's another example. I would say this is probably the more common appearance of transitional cell carcinoma. It's just kind of this hunky, irregular shaped structure just hanging off the side of the bladder. And they're pretty hard to miss unless you don't look all the way through the bladder. So make sure you're sweeping superior to inferior and left to right, right to left, all the way through. And that is the end of our bladder pathology. We are going to move to our last section, ureter pathology.